called me. He said
So you
10
want
to
to
15.
record the meeting right now, like even before it starts?
No, no, not required, sir. I'll just inform this to technical support. They are recording.
Okay, fine.
We'll
Not
wait,
a
sir.
problem.
10 to 15 minutes. We'll wait, sir.
Sure, sure.
But yeah, technical support. Just stop the recording. I will inform you.
Hello, everyone. Hello.
Sir, good evening, sir.
Good evening.
Sir, I am Kalim, sir, area manager, Supla, sir.
Okay. Hello, Kalim.
Sir,
I'm ready, brother.
sir, we are already having our one, yes, sir.
Huh?
5 our panelist doctors are there, sir, in the panel right now.
Okay.
You
Want to wait or should we start?
No, sir. We will start, sir. 1, 2 doctors they will join when we'll continue our session, sir. They will join in between, sir.
Please start it.
Sir, this slides you will be sharing, sir, or should I share?
Slides are there with me.
Slides already shared with you, sir.
The email or through?
From my WhatsApp they have sent, sir. If you want, I can also share. No issue, sir.
WhatsApp, you should not send slides. You should always send by mail.
No, my colleague has sent. Just check whether how he sent.
You can share, brother, slides. No problem.
Yes, sir. I will share. I will share, sir.
Please.
Sir, just want to just brief how, because we are having slides. First 4, 5 slides, sir. Your briefing is there, sir. Followed by our audience panel.
Yeah, that will be better if you share. That will be better.
Yes, yes, I will share, sir.
Dr. Ankit, how are you?
I'm good, sir. How are you, sir?
I'm fine, brother.
Long time, sir.
Long time, yeah.
Yes, sir. And how are things going on with your practice, sir?
This is going on. It's very busy.
Very busy. I can understand that, sir. I can understand. Have been to Gujarat lately, sir?
No. Actually, I don't have anybody in Gujarat, brother.
Acha, not anymore. No. Okay.
No, nobody is there.
Acha, okay.
They're born and brought up in Hyderabad only.
Acha, sir. Okay. Great, sir.
Yeah.
So, Mr. Kalim, are we starting now?
Yes, sir. Yes, sir. We'll start, sir.
Great. Okay. Yeah.
Sir, this is slides are visible, sir.
Yes, they are visible, brother. Go ahead.
So I'll just give welcome all the panelists and the moderator, Dr. Pankaj Jariwal, sir, to the student expert submit forum. So it is a great time we are associating, sir, and thank you all my doctors for your valuable time, sir. Before starting the session, I just wanted to give brief introduction about our moderator, sir. Dr. Pankaj, sir, is a consultant cardiologist, almost having more than 21 years of experience. Sir is a consultant cardiologist in Yashoda Hospital as well as physician of hospital. So this is a brief introduction about sir. Sir, now you can take over the session, sir.
Okay, so good evening, all the doctors, all the panelist doctors, and it's my pleasure that Cipla has given all of us to interact with each other through this academic session. And Dr. Dilip, Dr. Venkatesh, Dr. Ankit, Dr. Shashidhar Reddy, and Dr. Almas and Dr. Rajesh. I think welcome to you, all of you, for this session. And I think this is an interactive session, and all of you can share experiences with me. And so I think you may also having the vast experience of this. So mineralocorticoid receptor antagonist, a boon in the heart failure management. That is what we are going to discuss today. And the next slide. So this is the disclaimer. Next. So this is our opening remarks. Already the CIPLA team has done, and the presentation and discussion, and then the closing of the meetings will be there. So approximately 1 hour. We will try to finish as early as possible. Next slide. So objectives is to gain insights on the mineralocorticoid receptor antagonist placement and utilization in heart failure management. Hyperkalemia, is it a really concern in physician practice? And to create the awareness among the physicians on mineralocorticoid receptor antagonist. Next slide. So heart failure, as we know, that it is a very common problem, and nowadays a lot of drugs, a plethora of molecules. I would say there are few more molecules. I think in this month of June to September, we are going to get one more drug called vericiguat, which is also in the pipeline, and there are many other drugs they are going to get launched. And heart failure is not like disease previously where the outcome of the patients was very bad, and many of the patients, they used to die within 5 years of the diagnosis. But now, though it is a global problem, as our cardiology interventions, medical management, awareness has increased, and people are surviving little longer as compared to before, and we are coming up a problem of heart failure. So those patients who have some kind of risk factors, or those who have underlying heart disease, they are going into heart failure. It's very common. Just now in the clinic, before coming to this presentation, I saw just a 15-year-old boy who is having dilated cardiomyopathy and severe LV dysfunction, who is already on treatment, and despite of the treatment, he is having breathlessness. So 1 to 2% of the adult population in developed countries, and maybe in our developing country, we have few data. And also our prevalence of heart failure in our country also will be around 1 to 2%. But I think it is a skewed data. We don't know much because thorough evaluation of the heart failure incidence and prevalence is not common, is possible in our country because of the vast population, and going into the community and studying them is not highly impossible. So whatever hospital-based data what we have, that only we have. And prevalence in India, as I told you, is around 1%, and new cases of almost 500,000 to 1.8 million, so almost 2 million cases new year per year. So it is very wide range, as I told you, like 0.1 to 1. Maybe 2 million, 0.2 million patients individual per year, they die, and prevalence increases as the age increases. So this is all rough estimations and data collected from different studies. It is very difficult to, we don't have newer data available. This is all old stuff. Next slide. And in India particularly, so these are the questions. I think I need to read these questions, Kaleem, or the doctors has to read them?
You read the questions, sir. They will give their opinion, sir.
Okay, that's
actually
what.
First question, Madam Prashanti Madam is not there, sir. So that you can answer.
I can take up that question. Yes, so what percentage of the heart failure patient approach you in NYHA class 2, 3, and 4? And how many heart failure patient goes undiagnosed in India at an early stage, and why? So it's very good question. And
sorry to disturb you, sir. It is possible to on your this one cam, sir?
Yeah, I will do that. I'm trying, but yes. You can see me?
No, I can see you.
Yeah, thank you. So NYHA class 2 and 3, usually they are the patient, those who come to us on outpatient basis. And NYHA class 4, basically they are cases of acute decompensated heart failure. So usually they come to emergency department, and usually these patients are in the intensive care unit or maybe medical ICCU. And NYHA class 2 and 3 is very common problem. Percentage wise is very difficult to decide how many patients they come, but usually majority of the patients, they come in class 2 to 3, maybe I would say in a percentage wise, maybe around 70 to 80% of the patient. And remaining 20-30% of the patients, they come in NYHA class 4. That is, either they are cases of first new onset heart failure, and they do not know that they have heart failure, underlying heart disease before, and then any patient like who has acute myocardial infarction, or there may be a chronic heart failure and they come in acute decompensated heart failure. So the percentage vary because there is a lot of overlap between the percentage. Somebody who comes with a newly diagnosed like flash pulmonary edema, accelerated hypertension comes into NYHA class 4, or any patient who is already known case of severe left ventricular dysfunction and who has not been diagnosed, and when you do echocardiography, the patient comes, we see that patient is having some kind of left ventricular dysfunction, and then we say that. So this is regarding acute decompensated heart failure. So around 20 to 30% of the patient, and remaining 2 and 3 usually. Just now today I admitted one policeman who was referred to me by a pulmonologist, and he went to pulmonologist because he's getting PND episode, that is paroxysmal nocturnal dyspnea. When he's lying down in the night, he has to get up because he gets breathlessness around early in the morning. So he thought it is a lung problem. So he went to pulmonologist first. Pulmonologist did evaluation, including echocardiography. 2D echocardiography showed ejection fraction of 27%. And then he referred, pulmonologist is a good friend of mine. So he referred that case patient to me. And then I admitted that patient. So in NYHA class 3, basically that guy, because any PND episode comes into NYHA class 3. So he gets breathlessness on walking, less than routine. So that is NYHA class. So he came to me in outpatient department. He says, I am all right. Otherwise, I get only breathlessness when I'm in the lying down position. So otherwise, he says, I am able to do all my work. And he's a diabetic patient for a very long period of time. His diabetes was not well controlled. And recently, he started getting control of his diabetes. So I have admitted him for giving a decongestion by giving diuretics and other medications. And tomorrow he's posted for coronary angiography. So to rule out any ischemic cardiomyopathy or whether it is a non-ischemic cardiomyopathy. So how many heart failure patient goes undiagnosed in India? Like there are many patients, like the example we just now I discussed about the policeman. If diabetic of very long duration, if he would have gone for echocardiography before he would have got symptoms, we would have diagnosed that case in early stage. But now his ejection fraction is only 27%. So with the 27% of ejection fraction, how much recovery of his heart pumping will be there? We cannot predict at this point of time. Only the time can tell us once we do angiography, and if we find any multiple blockages, if we have to go for some kind of revascularization, either if multiple lesions, then CABG, or if any discrete lesions, then maybe angioplasty. And all the newer drugs like ARNI and SGLT2 inhibitors and mineralocorticoid receptor antagonists, diuretics, beta blockers, all these medications we have started him. So if you would have diagnosed an earlier, I think we could have saved his heart muscles little more. So all the diabetic patients, so there is ACC-AHA classification is there of heart failure, and there are stages are there, stage A, B, C, D. So stage A means all the patients, those who are at risk, like all the patients of hypertension, all the patients of dyslipidemia, all patients of diabetes mellitus, long-standing diabetes mellitus, they are not having heart failure, but they are at risk of getting heart failure. So that is very early stage. Like you get the diabetes or you get the heart failure, you get the hypertension, they should be screened with echocardiography on very regular basis. Maybe every 3 to 4 years at least they should go for echocardiography, so that at the early stage we can diagnose them. That is called as stage A. Stage B means asymptomatic left ventricular dysfunction. Means patient is having left ventricular dysfunction, but patient denies any symptoms. Like if you do echocardiography, patient will say that patient ejection fraction is something called 48%, 49%, maybe 50%. And then if you ask patient any symptoms, he says, I don't have any problem. So that is called asymptomatic left ventricular dysfunction, and that is stage B. Stage C means all symptomatic patient, whether they are well controlled on the medications, they are compensated stage, or those who had once a history of decompensation and they are on medications and they are well compensated patients. So they were symptomatic or they are symptomatic, but okay, they are on medications, they are well controlled, so they are called as stage C. And stage D is like end stage heart failure. Like despite of the medical therapy, patients are symptomatic, they are unable to do their regular activity, their quality of life is significantly affected. So all these patients, they are called as stage. So how many patients of heart failure goes undiagnosed in India at early stage? I think there are many patients. So exact percentage, I also don't know how many of them, but I think every patient who is diabetic, every patient who is hypertensive is a patient of heart failure. So I think it is a very large number of patients, and I think, and why? Because awareness is not there. It is not only the people, the general population, it is there at fault. But I think we, to some extent, we as a doctors are also responsible, because we are not screening them on regular basis by doing their echocardiography or cardiac evaluation on regular basis. And I think all the diabetic patient, particularly diabetic, because diabetic patient, they have very high incidence of developing coronary artery disease. They should be screened to know early stage of heart failure. That is very, very important. Thank you very much. And I think, Dr. Ankit, your question is, what are the diagnostic and prognostic tools used by you for heart failure patients?
Thank you, sir. And I think my experience and whatever I am going to say next is going to be just like a tiny drop in front of the ocean of knowledge that you have been delivering till now. So, in my limited experience, what I
Sir,
believe
please
is that,
on your camera, sir.
yeah, sure. So, in my limited experience, what I understand is that for heart failure to be diagnosed properly, we need proper clinical evaluation. And proper clinical evaluation works way better than any other investigation per se. So, what comes handy is the history, wherein the patient would definitely give a history of dyspnea on exertion, progressing towards rest. And that is how we go for NYHA classification later on. And then we have other anginal equivalents as well, which could be coming up. Then we have the patient complaining of orthopnea and PND. And these clinching points are very important in the history. And then comes clinical examination, where we look for a raised GVP, or we look for pedal edema, volume overload, bilateral basal crepitations or crackles, and such things on examination as well help a lot in diagnosing heart failure. So, as a rule of thumb, I think what we look for is the clinical as well as the history point of view on the examination of the patient to clinch a diagnosis. When it comes to laboratory findings, we all need to go for a cardio biomarkers, that is cardiac enzymes, and then we also need to look towards NT-proBNP. Not very well used, but has a lot of diagnostic as well as prognostic significance. Then you have routine cardiac workup, where you have all the kidney function test, electrolytes, your complete hemogram, and then workup for any other underlying disorder like thyroid or dyslipidemia. And once you have all this ruled out, then you start and initiate the patient on therapy. And the five basic treatments that need to be offered these days for heart failure happen to be beta blockers, diuretics, MRAs, and then you have SGLT2 inhibitors and ARNI, if the patient can go ahead and afford all the medications as advised. Then, once the patient is put on these medicines, to diagnose the reason for heart failure, what we need to go for is an angio. Probably a nice imaging would definitely go ahead. And then, before that, we need to go for cardiac imaging and echo and find out how the function of the LV is, how the size of the LV is, contraction, and how well the chambers are contracting, how well are they relaxing, and what are the dimensions of the same. So I think apart from doing an ECG, chest X-ray, 2D echo, and angio, clinical examination and the history of the patient plays a very important role in diagnosing as well as prognosticating a patient of heart failure. And I think with this, I think it should be sufficient to be answering this question, sir. Anything more that you would like to add, sir? Hello.
Sir, you are on mute. Sir, you are on mute.
Pankaj sir, anything more you would like to add upon?
You are very good physician. You are a physician who is sticking to the clinical diagnosis is very, very important. Actually, if you see, the heart failure is basically a clinical syndrome. It is only clinical diagnosis which is very, very important.
Yes,
So clinical diagnosis. So heart failure, if you see the definition of the heart failure, if you remember our days of MD, the heart failure says that it is a clinical syndrome basically. So you very well said that it is a clinical diagnosis. Thorough history taking and examination is very, very important. But these days we are doing NT-proBNP as one of the marker, which is very, very important. And there is a difference between BNP and NT-proBNP. Usually BNP is the base. NT-proBNP is like N-terminal prohormone brain B-type natriuretic peptide.
Yes, sir.
And it is like a precursor of BNP, and it do not change when you are giving medications like BNP. So BNP will change, NT-proBNP will change. BNP will not change. So that's why we do NT-proBNP very commonly. And these days, NT-proBNP is done in everywhere. It's very common. So these days in our cardiology practice, anybody who comes to us and says that they are getting breathlessness, first we do, because there is condition called heart failure with preserved ejection fraction also these days.
Yes.
So when ejection fraction is normal, still the heart failure can be there. Of course, apart from the clinical examination, history taking and all those things, I think what you have to go is to go for NT-proBNP. Very common, not very costly test these days. And every patient of breathlessness, of course, if there is no other cause like lung causes and anemia and obstructive sleep apnea and all these things, once you rule out coronary artery disease and everything, you should go for NT-proBNP. It has diagnostic and prognostic value also. More the NT-proBNP, more bad is the prognosis. And diagnostically also it helps very, very well. There are two more diagnostic and prognostic tools are there. One is troponin levels, like high sensitivity troponin levels also you should do. And then there is another test, but it is not available at all. It is like ST2 levels. So these are the one of the marker. It is actually ST2 levels. So basically BNP is actually a marker of myocardial stretch. All the chambers, as you said, there is an enlargement of the chambers and the stretching of the chambers. So whenever there is a stretching of the blood vessels, they are present in the blood vessels also. They are present particularly in the atria. They are more commonly found. And whenever there is enlargement of the heart, increase in the diastolic pressures, that leads to the elevation of the NT-proBNP. So it is basically a marker of the stretch and overload of the ventricles. And particularly troponin levels basically is a marker of myocardial necrosis. So muscles, myocyte loss or myocyte death of the myocytes. Myocardial injury, basically what we call it as. So if your troponin levels are elevated, that means muscles are getting dead. They are getting myocardial injuries happening. So these patients, they have very bad prognosis. Like somebody who comes to with us like myocarditis, like even COVID also, there were a lot of studies were there. And they said that those patients who had elevated troponin levels, they had very bad outcomes in terms of, because it suggests that patient is having myocardial injury or myocarditis, and many of these patients, they died. So if possible, do NT-proBNP in every case, wherever you think that there is unexplained breathlessness is there, and you have done 2D echocardiography, patient ejection fraction is less. So it becomes a diagnosis of heart failure with reduced ejection fraction. So less than 40%, we call it as a heart failure with reduced ejection fraction. Between 40 to 50%, we call it as a heart failure with mid-range ejection fraction. And more than 50%, we call it as a heart failure with preserved ejection fraction. So of course, if ejection fraction is less than 50%, we know that it is basically heart failure. But some of the patients with heart functioning more than 50%, ejection fraction more than 50%, and NT-proBNP levels are elevated, you can make the diagnosis that patients are having heart failure with preserved ejection fraction. Next slide, please. So these are the 21 updates to the 2017 ACC Expert Consensus Decision Pathway, and for the optimization of the heart failure treatment. And caution should be exercised when mineralocorticoid receptor antagonists are used. Sodium, particularly when potassium levels are more than 5 and there is a severe renal impairment. That is EGFR less than 30 and creatinine more than 2.5 milligram in male and more than 2 in female. Next slide. So Dr. Dilip is there. I think Dr. Dilip.
Sir is there. Dilip sir is there.
Yeah, Dilip sir. Are these parameters like potassium level, creatinine, and EGFR tested before and after initiating MRAs? How long? This is the question for your discussion point. You can unmute yourself and please discuss. I think he's not there.
He was there, sir. Just now, I think he.
Yeah, I saw him. He was there.
Yes.
So anybody else? Dr. Rajesh sir, how are you, sir? Rajesh sir.
Pankaj, I am fine. How are you?
I am fine, sir. Sir, you want to discuss this question, please?
Sure. Basically, the limitation of using mineralocorticoids antagonists would be actually given on by this question actually. So hyperkalemia is one topic of discussion where really how significant is it before you really consider dropping this off the treatment. Already we are evident that we are undermining and under-treating heart failures with this particular combination medicine. So what would be the ideal cutoff to consider hyperkalemia as a possible indicator of contraindication? Next scenario is very similar, renal function and electrolyte disturbance. So both of these parameters are related to particularly kidney. So kidney, as we get to see a lot of diabetic population now, there is a lot of kidney involvement resulting in kidney failures. So this drug would it complicate the scenario for us using it on a long term. So there was observation required in terms of monitoring electrolyte disturbance as well as the creatinine. So renal component plays a crucial role in considering this medicine. However, there is a balanced approach that should be looked at because this beneficial effects should be weighed upon when you are considering cardiorenal syndromes, because they play a crucial role in the management of heart failure patients. So I guess, this is how you should probably manage these parameters in considering heart failure, particularly with mineralocorticoid antagonists.
Yeah, very good. Very well said, Rajesh sir. Actually, most of the heart failure patient, if you see, they have cardiorenal anemia syndrome.
Yes.
They'll be having low hemoglobin. There will be little borderline creatinines, like 1.5, 1.6, 7 is very common. The moment you give diuretics, their creatinine increases further. And whenever they usually go into the state of little dehydration, because we are over giving diuretics for the control or decongestion of their symptoms. And usually they have cardiac problems. So mineralocorticoid receptor. So now the thing is that ACC is saying that there should be a sequential starting of these molecules. There should be rapid sequencing of these drugs. Like anybody who comes onto the outpatient department, like NYHA class 2 or 3, in those cases, you should start, or those cases of NYHA class 4, those who got admitted with NYHA class 4 acute decompensated heart failure, once they are stable, they are decongested, they are hemodynamically stable, and at the time of discharge, you should start these drugs to them. And as per the rapid sequencing, they are saying that you should start with SGLT2 inhibitor and beta blockers as a first line of therapy. And after 2 weeks, once they come to you for follow-up, and once their renal parameters come down, their diuretic dose come down, then you can start them on ARNI. That is maybe in the 3rd or 4th week. And then after that, maybe after 2 more weeks, you can start them on mineralocorticoid receptor antagonist. So this is called as rapid sequencing of the drugs. These are the 4 pillars of the heart failure at present, like SGLT2 inhibitors, beta blockers, ARNI, and mineralocorticoid receptor antagonists. So rather than starting all of them in one go, the rapid sequencing, up sequencing of the molecules has to be done. So first SGLT, because SGLT2 reduces the mortality, and beta blocker also reduces the mortality, because they are the drugs which prevents you from getting arrhythmias, and they are shown the various trials of SGLT2 inhibitors. We are using even in non-diabetic also. We are using drugs even in non-diabetic also nowadays. So all SGLT2 inhibitor, irrespective of the diabetic status of the patient, has to be given at the moment you diagnose, because SGLT2 inhibitor do not cause any electrolyte imbalance or do not cause much effect on the creatinine, and you can use them up to EGFR of empagliflozin like molecule can be used up to EGFR of 20 ml, and DAPA and CANA can be used up to the EGFR of 30 ml. So that is very, very important. Does not have any effect on hyponatremia or hypokalemia. In fact, I have given these drugs like EMPA and DAPA in patients of hyponatremia, those who are having heart failure. So it does not affect any electrolyte. And beta blocker, of course, is very, very important. And then you start giving them. So mineralocorticoid comes little late, and maybe after 4 to 6 weeks, once your patient's renal hemodynamic state, their E-volume, they are in the E-volumic state, not overloaded, not dehydrated. I think that point of time, all the time when electrolyte imbalance chances are very less, creatinine levels must have gone stable. I think that point of time, if you start them mineralocorticoid receptor antagonist, that will be more better. Next slide, please. So heart failure guideline recommendation for MRA, that is ESC 21, for heart failure with reduced ejection fraction and heart failure with mid-range ejection fraction. For reduced ejection fraction means heart ejection fraction less than 40%. It is recommended in all patients to reduce the risk of hospitalization for heart failure, recurrent hospitalization, and death. So that is class 1 indication. And MRAs in mid-range ejection fraction may be considered to produce further deterioration of the ejection fraction, that is class 2B. At present, we do not have very large data for the heart failure with mid-range ejection fraction, but I think if patient can tolerate, patient can afford, I think better to start. Because what happens in basically the main mechanism of mineralocorticoid receptor antagonist, it prevents the apoptosis, that is the suicidal death of the myocardial cells. So whenever you are giving these drugs like mineralocorticoid, the further deterioration of their LV function will be prevented. Next slide. So this is the overview as we were discussing. Can you make this slide little enlarge? There will be in the down. Yeah, thank you. So this is like management of heart failure with reduced ejection fraction. We start, as I told you, we start with beta blockers and SGLT2 inhibitor first, then ACE inhibitor or ARNI. ARNI is better. It is recommended now in all the patients of diabetic neo patients, heart failure neo patients, and those who are having ACE inhibitor, despite of on ACE inhibitor, they develop heart failure, better to switch them to ARNI. And then diuretics to be given for the decongestion. And patient, we need to see ECG, whether what is the ECG, LBBB is there, and whether it is how much is the QRS duration. More than 150, they respond well to the CRT, ICD, and these are the different therapies which are available. And you can consider them for bypass surgery or other management. And there are heart transplant and circulatory assist devices and all. Of course, they are very costly affairs, and very, very few patients can afford that. Next slide. So Dr. Rajesh, I think you can answer. He's there. Dr. Rajesh is there, I think.
Yes, sir.
Yeah, I'm there.
He's always there. So, so in what percentage of patient you use MRAs for heart failure management?
Yes, as we are aware that there is voluminous numbers of heart failure coming onto our clinical practice. The diabetic population is growing, hypertensive population is growing, end product would be having a heart disease, underlying coronary disease. So there's going to be a lot of people who would require this particular medicine in the management sequelae of the protocol that has been discussed. So for me, I would probably say it is going to be 100%, but is it really feasible to give it? So I guess it is there are certain limitations you have to look at. The mostly looked at profiles are the side effect profiles, tolerance of the patient, then hyperkalemia, like we discussed, kidney failure, and hypotension in particular. So if you were to really measure up and see how well, you can really consider this in the clinical practice. My ball figure would be around 30 to 40% of the people in the clinical practice with heart failure, you would probably, encourage them putting on this MRAs. Otherwise, in a clinical practice, in the ideal scenario, I would probably consider 100% because they play a bigger role in the prognosis and the reduction of the mortality in the long term.
Yeah, very well said, Rajesh sir. Actually, what I have seen is when patient is in early stage where he is little unstable, that time this hyperkalemia and dyselectrolytemia is very, very common. But if you see, there are many patients those who are chronic heart failure and they have improved. They are taking these mineralocorticoid receptors for many, many years, and
Yes.
they remain their electrolyte and all. They get stabilized somewhere, and they do not suffer any of these problems. So I think we need to, my only the thing is, message is we need to little wait for the patient to get stabilized. MRA is the last drug to be started. Of course, it has very good morbidity and mortality reduction. And what we use is basically aldosterone antagonist, that is spironolactone, or we can use eplerenone. And then there is one more new drug is going to come now in the month of June. That is finasteride, basically, and it does not produce any hyperkalemia. It is a non-steroidal mineralocorticoid receptor antagonist. So that drug is going to come very soon. And I think particularly in patients of diabetic nephropathy, it has shown very good response in terms of reduction of the progression of diabetic nephropathy without causing any hyperkalemia. So such new drugs are also coming up with us, where we can use them. And this group of mineralocorticoid receptor antagonist is getting enlarged now, and our experience also is increasing day by day. So the next question is to Dr. Sandeep, if he is available. And when do you consider starting MRAs in patients with heart failure along with ACE inhibitors and ARB and beta blockers? I think we have answered this question to some extent, but if doctor is available, I think he can answer that. Otherwise, if anybody else would like to answer this question and take up this question and answer, that will be, somebody wants to volunteer. And I'm seeing Dr. Venkatesh for quite some time. He's with a lot of interest, he's listening. Thank you, sir. And would you like to highlight this question, sir?
Sir, you are on mute, sir. Venkatesh, sir, you are on mute. Unmute, sir.
Hello.
Sir.
Am I audible?
Yes, sir. Yes, sir.
So, my experience says that I'll start this MRAs if the signs of decompensated heart failure is there. So, I'll do echo. If the ejection fraction is less than 50, I will start. And after screening for all these, renal parameters and electrolytes, I will start.
So do you start along with the ACE inhibitors or ARBs and beta blockers, or you wait for some time to start the MRAs?
I wait for some time, sir. Yeah. Meanwhile, if the remodeling, all those things over, if still his EF is less than 50, I will start.
Yeah, it is a good thing, sir, you are starting, but it should not be very late. As good as possible once patient is stable and all other drugs are in place. I think you should start within maybe second or third follow-up. That should be at the earliest to start the drug. Of course, your follow-up should be like first follow-up. Usually I do maybe around 10 days, 1 week to 10 days, and maybe second follow-up in 1 month. So within 1 month, if we start the MRAs, that will be more better for the patient because we can reduce their mortality further down. Thank you, sir, for your very good answer. Next, please. Next slide, please. So aldosterone escape in congestive heart failure, there is something we need to understand. This is very, very important concept. And importance of time of initiation of mineralocorticoid receptor antagonist. was studied in this on the risk of mortality in patients with heart failure, and use MRAs as early as possible, as we discussed, on the top of the treatment, including ACE inhibitors and ARBs and beta blockers, preferably at discharge after the episode of decompensated heart failure. What is their recommendation? And following acute fall in aldosterone in response to administration of ACE inhibitor, the level of aldosterone rises again. So that is what we call it as aldosterone escape. And when ACE inhibitors are given in combination with ARB, aldosterone levels remain. Of course, this is very old data of 2015, and these days nobody will give ACE inhibitors and ARB combination. It is a detrimental combination. It should not be used. After on-target trial, which was done, where they use ramipril versus telmisartan versus ramipril-telmisartan combination, they banned this combination of ACE inhibitors and ARBs because it led to tremendous hyperkalemia when patient develop any dehydration, like loose motions, vomitings, any fever. So this combination should not be given, and progressive escape of aldosterone contribute to the ACE inhibitor resistance also. So that's why MRA needs to be given, because it is basically the end target. It's basically receptor antagonist. So where the aldosterone is acting, there itself it blocks the pathway, and that's why ACE inhibitor can work in a little better way. So this concept, I agree upon it. But giving combination of ACE inhibitor and ARB should not be done at any cost. And MRA at the time of discharge, I do not agree with this concept. I think we need to wait little more for the patient to come little for follow-up. And I think when little he is stable, I think then we should start at within 1 month, definitely within 4 to 6 weeks. I would recommend that MRAs should be started. Next slide. So this is improvement in the systolic function was significantly more in the eplerenone study. This was a comparison between spironolactone and eplerenone on LV systolic functions in the patients with chronic heart failure. And I think it's one of the very rare study where the spironolactone and eplerenone has been compared. I think this is one of the only study which is available and which has shown that there is a good response of change in the LV function, volumes and dimensions after 6 months of treatment, where they have compared spironolactone and eplerenone. I think the comparison between the same group of molecules, hardly we have many studies available, and I think this is one of the wonderful study. And we can imagine that the study is done by Bangladeshi people. It is a study from Dhaka, done in Bangladesh. So they have done such a wonderful trial of the study of almost 224 patients, and they demonstrated that it improves the good ejection fraction with eplerenone. Next slide. So question 7 for Dr. Shashidhar. I think Dr. Shashidhar is there, and I appreciate that he's listening with a lot of interest. So when do you prefer using eplerenone and spironolactone, and any patient-specific profile you want to discuss?
So good evening, sir. So usually we use this mineralocorticoid receptor antagonist in the heart treatment of heart failure, sir. Apart from this, I'll also use in patients of decompensated chronic liver disease with portal hypertension and ascites, sir. And also I'll use in patients with new younger patient. Recently I have one patient, sir, with hypertension with hypokalemia. Might be due to Conn syndrome or some other. And when the patient is presented with hypertension with hypokalemia, usually they are resistant, sir. They may be hyperaldosteronism. So in that scenario also we can use, sir.
Primary hyperaldosteronism leading to refractory hypertension is one of the very common cause of spironolactone. So where the eplerenone may not work, spironolactone works very well. Another indication of using eplerenone is patient developing spironolactone induced gynecomastia, like painful gynecomastia when they develop. Like when we see many of our patients will be on drugs like placilactone or frucelac or Ditor Plus, and many years they are taking, and they will come and tell us that they are having enlargement of the breast or they have painful gynecomastia. So in those cases, eplerenone to be used. Eplerenone to be used in patients those who have post-MI heart failure, like somebody has got extensive interval MI, FSS study was done particularly in post-MI patients. So particularly those who have coronary artery disease, ischemic cardiomyopathy, or basically post-myocardial infarction, severe LV dysfunction, eplerenone do very well as compared to spironolactone. Spironolactone do very well in patients of chronic heart failure where there is a non-ischemic cardiomyopathy, and in those cases that this study was studied very well. And this is one of the very old drug. And next slide, please. So spironolactone and eplerenone dose adjustment proposal is there, hyperkalemia management, and the baseline EGFR should be dose adjustment for spironolactone more than 50, and you can use dose of 25 milligram per day, and if EGFR between 30 to 50, you should use spironolactone alternate day. This is what it is recommended. And if the potassium is less than 4, increase the dose of spironolactone 25 milligram per day. That which patient is already on, increase to 50 milligram per day. And if spironolactone dose is 25 mil every other day, increase through 25 milligrams per day. So from alternate day, you can make it per day. Between 4 to 5, there is no dose adjustment is required. Between 5.5 to 5.9 potassium, is spironolactone dose is 50 milligram, decrease to 25. If there is a 25, make it a very alternate day. And if the every other day this patient is still developing hyperkalemia, better to stop the drug and then reassess it. And more than 6, we have to stop. And like eplerenone, again, I think we should start with more than 50 EGFR. 50 milligram is the recommended dose, and between 30 to 49 eplerenone recommendation is 25 milligrams per day. So that is what we saw in the spironolactone. And if the dose is potassium is less than 4, increase to 100 milligrams, and if it is 25, make it 20, double the dose. Between 4 to 5.4, no dose recommend is required. Just continue the medications. And in bit again, there is hyperkalemia, you need to reduce the dose by half. So very well, dose adjustment protocol has been described here. And the problem is eplerenone 50 milligram is not available in the market. And maybe you have to give 2 tablets of eplerenone, what we have. Next slide. So Dr. Venkatesh, I think you are there.
Yes.
Dr. Venkatesh is there.
Yes, sir.
Yes,
So what
sir,
is the preferred dose, and how is the dose titration carried out in your practice?
So most of them, my answer is prefer.
Yeah, sir.
Yeah, it was, I mean, well explained by you, sir, in the previous slide.
Yeah, thank you, sir. So we'll go to the next slide, sir. It was very well explained. I agree with you. Next slide. So actually, more or less, we are doing adjustment of the dose, though it is proposed in the protocol. But as all our physicians and doctors, they are very well experienced, and they know how to adjust the dosages depending upon the potassium. And also the protocol which we saw, I think it is there for most of the drugs. Whenever we get blood sugar elevations or maybe blood pressure, we adjust the dosages in the similar manner. So whether so it is more or less, it is a practical protocol basically.
Practical
I will say that it is not any specific protocol for these mineralocorticoid receptor antagonist. So MRA related hyperkalemia, true rate of mineralocorticoid receptor antagonist related hyperkalemia, and this was basically a meta-analysis. And what they studied in this study is prevalence of hyperkalemia was 9.3%, out of which 54% only were fully related to the drug. So the different trials you can see which were done, like post myocardial infarction. Dr. Shashidhar, you can see the FSS trial has been mentioned here. FSS was done trial in post myocardial infarction and reminder trial. And post myocardial infarction, heart failure, RALS, emphasis, TopCat, Aldo DHF. So these are all the trials, and they found that only very few patients they develop, 9.3% patient develop hyperkalemia in all patients versus placebo. Next slide. So what percentage of heart failure and MRAs develop hyperkalemia and do they require discontinuation of treatment? Dr. Adi Nagesh, if you are there, can you answer this question, please? I think you are there, sir. Quite some time I am seeing you. Thank you for joining. You need to unmute yourself, sir.
Sir, usually this hyperkalemia, the side effect happens when the treatment is combined with AC inhibitors and angiotensin receptor blockers. And potassium supplementation is generally stopped after the initiation of MRAs, aldosterone antagonist, and patients should be counseled to avoid high potassium containing foods.
Yes.
And in acute treatment, we should give IV potassium gluconate. Sorry, calcium gluconate. IV calcium gluconate should be given 10 ml as a 100 ml infusion. And there are two new potassium binders are there available in the market, patiromer and sodium zirconium cyclosilicate. They have been studied in heart failure patients with hyperkalemia. Here, patiromer is an FDA-approved non-absorbed cation exchange polymer that contains calcium sorbitol counterion and works by binding potassium in the lumen of GIT, gastrointestinal tract, resulting in reduction of potassium levels within 7 hours of the first dose. But this is having a delayed onset of action. Therefore, the initial clinical studies in patients with heart failure have shown that these therapies reduce potassium and prevent recurrent hyperkalemia in heart failure patients with chronic kidney disease who were receiving RAS inhibitors.
Very nice answer, Dr. Adi Nagesh. The very important highlight point what you made, which I liked, is avoid potassium containing food.
Yes.
That was actually very good advice we should give to the patient. And I learned from you also that we should tell this point particularly to the patient that they should avoid the potassium, like banana, ripe fruits, and maybe coconut water,
orange.
ORS. All this should be avoided, and they should monitor the potassium levels very closely. So once we start the mineralocorticoid receptor antagonist, I think we should monitor their potassium initially maybe every month for first 3 months, and after 3 months, I think every 3 months renal parameters should be checked for this patient to know whether they are developing any hyperkalemia or not. And particularly those patients, those who are on ACE inhibitors and ARBs in combination, when we are giving drugs like MRAs, we have to be very cautious. And any episode of dehydration they develop, like they develop gastroenteritis, or whether they develop any fever, if they are going for any non-cardiac surgeries like appendicitis or lap chole or any hernia surgery or any surgery, we should stop this drug, because once they become dehydrated, their level of potassium levels will increase. So we need to be very cautious while giving these drugs to them, and we need to tell them but these days the good thing is that most of these patients will be monitored by the physicians and cardiologists. Whenever they take the opinion of us before giving fitnesses. So when we are seeing this drug, at least we will be able to temporarily halt them so that they do not go into the hyperkalemia. So, and I think you also answered, if yes, in how many percent and how these patients, I think you already answered how these patients are to be managed. Already you told the treatment of
percentage I could not found in any text. The percentage I could not found.
Percentage is difficult, sir. This is just a general practice. What we experience, that is, we are taking your feedback on the experiences. And as you can see, the percentage was already mentioned in the study. They said that it is 9%.
9%.
So we can say that 9 to 10% of the patients, they develop hyperkalemia when they are taking mineralocorticoid receptor antagonist. So that is what the considered as a standard answer for this question.
And basic investigation we do for that is ECG we should do, sir. ECG.
Yes, ECG is very important. And these days, in most of the emergency departments, arterial blood gas analysis are available. In that you get the electrolyte very easily. Just add pinprick and you get the potassium levels of the patient. May not be very correct, but plus minus
Approximate. Okay, sir.
approximately we'll come to know, and how much is the potassium level. So you need not wait the laboratory to give the report, and you can start giving corrections to the patients the moment you get the hyperkalemia to the patient. So simple is to give Lasix injection, that is furosemide injection, and Astalin nebulization, calcium gluconate, 25% dextrose insulin.
Insulin.
And, yeah, and if this still they are not able to control, we usually call our nephrologist for doing any dialysis. And many of the times when patient has in bradycardia, we sometimes usually do a temporary pacemaker implantation also to temporarily increase the heart rate of the patient. But those who have very severe hyperkalemia, like potassium more than 7, sometimes they even may not respond to the temporary myocardium unresponsive, and patient usually goes into cardiac arrest. So we need to, it is sometimes it is very dangerous. Hyperkalemia needs to be very cautiously, and I would say that we should over cautious when we are giving drugs like ACE inhibitors, ARNI, and ARBs along with mineralocorticoid receptor antagonist. Next slide, please. So the timing of iprinone initiation and outcomes in patients of heart failure with acute myocardial infarction complicated by LV dysfunction, insight from FSS trial. Can you enlarge this slide? Yeah, so around more than 6,000 patients, and in this trial, what they studied is median time of initiation less than 7 days, that is earlier, and more than 7 days, that is later. And they say that earlier administration of between 3 to 7 days post MI improved the outcomes of patient with LV systolic dysfunction and heart failure. And this benefit was not observed when iprinone started later. So this is basically what we were discussing till now was patient for heart failure, like chronic heart failure. But this is a special recommendation based on FSS trial in post MI patients. So in post MI patient, iprinone should be started earlier, like within 7 days, so that patient can benefit better, because acute myocardial infarction leads to the severe left ventricular dysfunction, and starting early them will make them reverse remodeling of the LV in a better way, so that by the time the myocardium is already lost, if you start them drugs like iprinone, there will not be much usefulness of this drug to them in a later stage. That is what we understand the mechanism of this iprinone of starting earlier in patients of post myocardial infarction. Next slide. So earlier administration, as we saw, improved the outcomes in patients of LV systolic dysfunction and heart failure in post MI patient. There was 31% reduction of all-cause mortality and 34% reduction in sudden death in patients of heart failure with post MI by iprinone versus placebo when started before 7 days versus later. Next slide. So last question, I think, in clinical practice, how early MRAs are initiated for management of heart failure? I think we have discussed this question even before, and I think most of our doctors, they start MRAs very early, and in post MI, I think within 7 days, and in remaining other cases within 1 month, 4 to 6 weeks. What is the recommendation to start the MRAs? Always, if your patient is more stable, always try to give the drugs as early as possible. Next slide, please. So this is a therapeutic algorithm, and for class 1 therapy for indication. So ACE inhibitor, ARNI, beta blocker, MRAs, DAPA, EMPA, and loop diuretics for your fluid retention. So all this drug has to be must. And if ejection fraction is less than 30%, QRS less than 130, it is ICD is recommended for ischemic cardiomyopathy and non-ischemic. Of course, in ischemic cardiomyopathy, you have to do revascularization first. And if the revascularization still is not able to increase the ejection fraction of the patient, then only you should go for AICD. If patient ejection fraction improves beyond 35%, you need not go for AICD. For non-ischemic cardiomyopathy, minimum you should wait for the medical management to happen at least for 90 days. Even in post-myocardial infarction also, we do not recommend AICD for first 90 days. We try to wait patient ejection fraction to improve on the medical therapy, angioplasty, whatever we have done. And if after 90 days still the ejection fraction is not improving and remains less than 35%, they are the candidate for AICD. Problem is it is costly device and everyone in India cannot afford it. And if more than EF more than 35%, it is not indicated, as I told. And patient has QRS duration more than 130, like patient is having left bundle branch block, they should be offered CRT or CRTD. Again, it is costly affair. And if still patient consider symptoms are there, then there are class 2 recommendations are there. Next level of drug should be used. Next slide. So at what stage heart failure diuretics and MRAs both are needed? What is preferred choice of therapy? So I think every one of those who are there, at what stage of heart failure diuretics and MRA both are needed? I think all the patients, those who are well compensated, initially decompensated, we give the diuretic therapy. And as they go towards the stage of compensation, we start giving them diuretics and MRAs as we discussed. And what is preferred choice of therapy? I think I will like to take the opinion of the panel, whether they start eplerenone or eplerenone with torsemide, spironolactone with torsemide. So Venkatesh sir, you can answer this question from first.
So, say as the eplerenone is a very costly drug, I start spironolactone with the torsemide, sir.
Very good, sir. I think there are doctors like Almas and Dr. Prashanti, madam. Also, they can unmute. I think they have not spoken, and I think they are there in the meeting. If they can identify themselves and share their views also, that will be a great. Prashanti, madam. Dr. Prashanti, your question was there first. Actually, other doctor has answered that question. Dr. Adi Nagesh or Dr. Shashidhar, what is your preferred choice of this molecule?
I used to prefer the diet torsemide with spironolactone, sir, combination, because it's a combination tablet, sir. Easily patient can be easily taken. Whereas the torsemide with eplerenone tablet is different form, sir. We have to take 2 tablets. Yeah. Sometimes the patients are skipping, sir. That's what I observed, and it is costlier also. But as you said, if someone developing complications like gynecomastia and all, and if they are affordable, then we'll go for torsemide with eplerenone combination. So if they are well educated.
Actually, the advantage of keeping 2 tablets separately is that you can ask your patient to take them alternate also, so that they can save the cost. Usually, many of my patients, those who are well stable heart failure, and if they say they are developing heart failure, there are 2 tablets are there. One is red and one is white. So I ask them to take one day white and one day red, so that they don't go into hyperkalemia and they get good response of the medications also. And the cost also will be saved to them because they are taking alternate day, and hyperkalemia do not develop. So very few patient requires torsemide 10 milligrams and eplerenone every day. Very few patients, like those who are like end stage heart failure, only will require the very high dose of diuretics. But because of the newer drugs like SGLT2 inhibitors and ARNI and all, these days, a lot of patients, I would say that 90% of the patient, they get decongested and their recurrence of the heart failure is coming very significantly down. So once their heart failure is well stable, usually I try to give them alternate days of therapy so that they get benefit of it.
Sir, I have one doubt, sir. When to stop this ARNI, sir, and after 6 months?
No, ARNI has to be given lifelong. And there are those patients.
Few patients, they have improved their EF, sir, from 30 to 40.
Yeah, very good question. Then you asked one of the question, which was actually, the study was published in Journal of American College of Cardiology. And what they said that if you stop drugs like ARNI, they go into the withdrawal state. So they can have their the deterioration of their ejection fraction again. So those who have improved, what we call it as a heart failure with improved ejection fraction. There is another new terminology is there. Improved means somebody whose heart function was 30%, and became 45%. So we call it as heart failure with improved ejection fraction. And there is one group of patient called heart failure with recovered ejection fraction. Like means they have recovered their ejection fraction completely. Like they became 60%, which was initially like, so these are the many cases of reversible cardiomyopathy. Like there are cases of like post-peripartum cardiomyopathy, or there is a condition called hypocalcemic cardiomyopathy. Very rarely we see these cases. Post-myocarditis, they had LV dysfunction and then they have recovered. So these are the cases of reversible cardiomyopathy.
Scorpion bite myocarditis. Sir.
Yes, sir. So such cardiomyopathy may not recur again. So like somebody, the lady is not going for pregnancy again. Usually peripartum cardiomyopathy, we say that don't go for again pregnancy. So only pregnancy can aggravate their LV dysfunction. So if she's not going for pregnancy, it is no chance that she will have again the heart failure and LV dysfunction. So in those cases, you can stop without any problem. Like reversible causes of cardiomyopathy. But where there is a cause is not known, or like somebody is having ischemic cardiomyopathy, if a patient has suffered a large interval myocardial infarction, where a lot of myocardium muscle loss has happened, and patient has developed severe LV dysfunction, in those cases, you need to continue them for lifelong. So particularly heart failure with improved ejection fraction, where ejection fraction still remains low, but it has improved. So in those cases, if you stop, they can go back to the same ejection fraction. And this was very good paper was published in JACC, and they said that the withdrawal of the drug can happen in those group of patients. So they need to be continued lifelong.
Sir, after improving the EF, should we reduce the dose of Ajmada?
No. You need to escalate the dosages. You need to escalate the dosages. As whatever the tolerant patient can tolerate. If patient can tolerate 200 milligrams, better to go to 200 milligrams. But depending upon the blood pressure. Of course, the cost effectiveness is the question. But I think in the year end, this drug is going off patent now. So the cost will come down significantly by January 2022. And I think this drug will be available off patent, and you will be able to give ARNI without any problem to your patients. It will be cost effective drug.
Thank you.
Next slide, please. So all panel members in your practice, any other indications apart from heart failure where MRAs were used? I think Dr. Shashidhar already has answered this question, and he said all the indications, and we also discussed it. And what are the scientific initiatives would you suggest to CIPLA for increasing awareness among the practitioners? So any insights you want to give to your other practitioners, what CIPLA wants to know? Next slide. Meantime, you can discuss. Thank you very much for your patience hearing.
Thank you.
Thank you, sir.
Thank you.
Yeah, I think CIPLA, I would like to say only one thing is that continue doing such kind of education among the doctors and physicians, and we also learn a lot. As a speaker, I also learned a lot from these experiences of other doctors, and the knowledge sharing is the only strongest way of boosting your business and the patient benefit and increasing our knowledge. So sharing knowledge and education is the most important key for everything.
Yes, sir. Kalim here, sir.
Yeah, please.
Sir, thank you, sir. Thank you for a valuable suggestion, sir. So we have come to end of the session, sir. So now we can close this session, sir. From our CIPLA team, I really want to thank all the panel doctor and especially Dr. Pankaj Jariwala, sir, for a valuable time, sir. Thank you for your time, sir.
Thank you everyone. Dr. Venkatesh, Shashidhar, Adi Nagesh, Dr. Kalim, Sandeep, Dr. Rajesh, Ankit, Saxena, then Dr. What is madam's name? I forgot. Prashanti madam. Thank you everyone, one and all. Thank you.
Thank you, sir.
Good night.
Good night.